Good afternoon, everyone. Thank you for coming along, taking part in the Genomics England Innovation Showcase. My name is Simon Wild. I'm the Director of Engagement at Genomics England. Welcome to you all. This session is titled Newborn Sequencing, the Value and the Vision. And for the next 90 minutes, with the help of a distinguished panel we have here, we want to tell you the story so far of the Newborn Genomes Programme, a new initiative that Genomics England has begun to explore the potential of using whole genome sequencing to increase the diagnosis of rare genetic conditions in newborn children. Please join in with your questions in the Q&A chat, and we'll try and answer as many of them as we can. Just before we begin, I want to emphasize that we're at a very early stage, that our work so far has been listening to and engaging with a wide range of different people and organizations, and that there will be a lot more listening, talking, and engagement before we are in a position to begin any kind of pilot research program to sequence newborn babies. As with any new technology or new use of existing technology, there are a huge number of scientific, technical, ethical, and societal challenges to overcome. But we'd like to describe to you today how we collectively might go about tackling these challenges and potentially realize the benefits that genomics might bring us. The other thing that I'd like to mention, for the avoidance of any doubt, is that everything we'll be talking about today is about postnatal sequencing and not pre- or antenatal genomic testing. In this session, we're going to be hearing from panelists from Genomics England who have been working on developing a vision for the Newborn Genomes Programme, and from those whose work has already had an impact or will maybe have their work impacted on or by developments in this area. So without further ado, let me introduce today's panel. They are Professor Neena Modi from Imperial College London, Rebecca Middleton, who is Vice Chair of our Genomics England participant panel, Catherine Joynson, who's Assistant Director of the Nuffield Council on Bioethics, Sarah Jane Marsh, who's joining us live from Birmingham, who is the Chief Executive of Birmingham Women's and Children's Hospital. Hello, Sarah Jane. And joining me from Genomics England, Rich Scott, our Chief Medical Officer, and Alice Tuff-Lacey, who is our Programme Lead for the Newborns Programme here at Genomics England. So, why newborn sequencing? The idea itself is not a new one. In fact, I learned only recently that in 2001, the same year as the first draft of the human genome was published, Francis Collins, one of the pioneers of the Human Genome Project, predicted that it would be feasible within 20 years to produce a kind of report card analysis from a baby's DNA sequence. Well, here we are in 2021, where our achievements in using genomics, and in particular whole genome sequencing, in the NHS you've been hearing about this morning. But without wanting to take anything away from Francis Collins' prediction, a report card analysis probably raises more questions than it answers. What might the possibilities of using data from our genomes to improve our health be? And in particular, what might be the benefits of analysing our genomes proactively at birth? We already have the NHS Newborn Screening Programme, which tests for 9 rare inherited conditions through a blood spot heel prick test just after birth. Can we, and if so, should we, be looking further than this? To help me explore the potential possibilities of using genomics at the start of life, I'm delighted to be joined first by Neena Modi, Professor of Neonatal Medicine at Imperial College London, who for many years has been involved in research and the clinical care of newborn babies. Professor Modi, thank you very much for joining us. So for the past 14 years, you've been running the Neonatal Data Analysis Unit. Can you tell us a bit about what the National Neonatal Research Database does?
Of course, thank you very much, Simon. It's great to be here. So my research group runs something called the National Neonatal Research Database, and also another database called the International Neonatal Research Database, 2 databases which are built on the view that families should not be asked the same questions again and again and again, but you ask a question once, record the information, and then make it available for appropriate use for all the other reasons that one might need information for. And also, busy clinical teams shouldn't be asked to record the same information again and again and again, and nor should researchers. So that's the very simple principle behind these databases. But what we've done more recently, which is why I think I come to be with my colleagues here today, is that we've also done exploratory work to obtain the views of families of linking this routine clinical data about sick and preterm newborn babies to DNA samples which are used for genetics analyses. And that pilot project, which we did a short while ago, has really, for me, opened up a really deep understanding of the possibilities of obtaining DNA samples from newborn babies and then storing it for uses such as whole genome sequencing and all of the other very many potential benefits that could come from it. Now, we have the wherewithal to do this nationally, and we pretty much have the wherewithal to do this beyond the UK borders as well. But I have to say that the UK is doing a great job in doing this cautiously, carefully, and taking into consideration the views of all of the various stakeholders involved.
Thanks, Neena. So you talk about possibilities here. What do you think the possibilities from collecting, analysing the genomes of newborn babies just after they're born might be?
So many, so many. So let me give you one example from our pilot project. We wanted to do the study both in order to obtain the views of families, but also to answer a really important research question. And the research question was, are very preterm babies enriched, is their DNA enriched for genetic variants that are known to be linked to later neurological disorders like autism spectrum disorder? So that was the research question, but we also wanted to get the views of families about how we went about doing this research. And the answer to the research question was yes. Yes, very preterm babies, so in other words, babies born between 2 to 4 months earlier than their due date, are genetically, they do have markers that show them to be susceptible to a range of later developmental disorders. Now, whether these developmental disorders are actually going to emerge, or whether it's just that the genetic markers are there, is another series of research questions. And so research always opens up new frontiers, and you go from one bit of the jigsaw puzzle to the next bit of the jigsaw puzzle, and that's how science progresses, and that is why it is so fascinating.
Absolutely. And in terms of, not just talking about, preterm babies or babies that are born ill, expanding this out to a kind of wider cohort of babies that actually, when they're born, may not appear to have anything wrong with them. What might be the benefits, both for clinical practice and for research?
So there's a lot of talk about, the phrase is used, the life course approach to life. That's a very appropriate phrase, I think, to use, because we are born with a certain genetic set of determinants. Whether or not those actually translate into real illnesses further down the line, in childhood, in young adult life, in old age, is uncertain, because genes have to be expressed. So understanding the interaction between what you're endowed with genetically, what your subsequent life course exposures are, and how these all interact, is one of the great opportunities for the future. In other words, all of us here want to have we want to be healthy in our old age. We are going to be susceptible to a whole range of disorders that increasingly we're vulnerable to as we age. But if our genes can tell us something not only about our original susceptibilities, but how those genes interact with the way in which we live and work, exercise, play, then surely it puts us more in control of having that healthy old age. And that, I think, is what no one would not wish to aspire to. So whole genome sequencing opens up a huge range of wonderful possibilities, not only about rare diseases which might affect a newborn baby immediately, or in infancy or in childhood, but also about diseases that may have their onset later on, and also about how we can take control of our lives and reduce our risks. So enormous possibilities, but it starts at the beginning, and it starts with engaging with families, ensuring we can actually obtain samples from which we can extract DNA and then sequence the genome and use it in ways that are wise, careful, considered, and done in conjunction with the families whom we care for.
Thanks very much, Neena. So you've started to touch there upon the kind of, the possibilities, but also the kind of fact that, if we're going to do anything like this, it really needs to kind of bring the families along with us with a careful consideration of all the kind of issues that are raised. And I want to turn now to Catherine Joynson here. Catherine, you are Assistant Director of the Nuffield Council on Bioethics, and you were part of the Nuffield Council team who have been looking at the ethics of whole genome sequencing. And in 2018, you published a paper looking at this issue in particular. What was it that prompted the Nuffield Council to have a look at this particular topic?
Well, that was part of a really long-standing interest for us in this area. In fact, our very first report 30 years ago was on genetic screening, as it was more called then. But what prompted us in 2018 to particularly focus in on newborn testing and screening was, I think we were moving there more from a sort of theory to reality. So we had the Chief Medical Officer's Generation Genome report, which set out a vision for genomic healthcare, had the 100,000 Genome Project, which was bringing whole genome sequencing into the NHS. But also, we saw a rapidly expanding commercial sector where, many more people were choosing to have their genetic profiling done. So we thought it was a good moment to take stock and set out what some of the issues were.
So tell us a little bit about what was in this report then. What were the main ethical issues that were identified?
Well, I'm going to talk a little bit about that, but I think as well as some of the things we've learned over the last 3 years since that report, and I knew you were going to ask me that question, so I've got 5 areas I just wanted to mention. But firstly, to say that none of these are particularly new issues, and none of them are particularly unique either to this area of healthcare. And also, I wouldn't want to suggest that the people working in this field aren't already very aware of these issues and working on them. So the first area to mention is sort of the big one really, which is how you get the balance right between the potential benefits of this technology and the potential harms and risks. I think it's generally accepted really, many countries across the world, that newborn screening should focus on serious, actionable childhood conditions. But that doesn't tell you everything you need to know, and different countries interpret that in different ways. In the US, for example, they screen for many more diseases. So perhaps does whole genome sequencing and also our increased understanding of rare genetic disease, does that mean we need to rethink how we approach newborn screening? The second area is around children and consent to screening, or any medical treatment actually. So this is proxy decision making. It's the parents that make the decisions. So in order to treat those children and the parents with respect, we need to give them the information that they need to make those choices and support afterwards as well. So that's a really important area, and I think it raises questions around capacity and skills within the NHS in order to enable us to achieve that. The third area is around genetic information, which is special. It's very private, very sensitive. I think we're all aware that we need very secure data protocols here, but we mustn't be complacent. Data breaches happen, mission slip happens, that would have a huge impact on public trust. So we need to make sure that we are considering all the time how this data is being stored, and also that people who are signing up to be involved in research or having their genome sequenced are confident that their data is going to be secure. The fourth area is around fairness, and this is becoming a really important concept in public life. How can we make sure this technology benefits everyone? How can we ensure some people aren't disadvantaged? We live in a very diverse society, and families come in many forms. We need to make sure that we're thinking about everyone here. And we also need to think about fairness in terms of public resources as well. Is this a proportionate use of public funds? The fifth area is a different kind of ethical issue. It's around procedural ethics. How do we sort all this out? How do we decide what is the right way to go about this, or the best way to go about this? Whose voices are carrying most weight here? Are we being transparent in our processes? What factors are most important? So that's going to be really important as we go forward, to make sure we do this in the right way, and to make sure that we can make the best of this technology without over-promising and hype.
Yeah, lovely. That's a really, really useful kind of summary of the kind of main issues there. So I think 2018 was when the Nuffield Council report was published. Since then, there've been various documents that have been produced. Sally Davies, the then Chief Medical Officer, produced her Generation Genome report not long after then. And as a result of that, Genomics England was asked to kind of set up a task and finish group to look at the use of genomic analysis in children. And you sat on that group, I think, along with Professor Modi here. What were the kind of main considerations that the task and finish group considered?
Yeah, so that group looked at both the use of whole genome sequencing in acutely ill babies and also in apparently healthy babies, so the screening side of things. I think we quite quickly came to the conclusion that the former was fairly uncontroversial, and we focused most of our time on the latter. We concluded that we would be supportive of exploring the feasibility of using whole genome sequencing in newborn screening through a research programme. So that was, very importantly, the first step to look at it through research. But we highlighted that there were some important ethical and societal issues to work through, and that public and patient involvement should be core to the future of this.
Yeah. So you've mentioned public trust in your earlier comments, and you're talking about kind of making sure that the public are kind of consulted and involved in decisions that ultimately will affect them. So you were involved, and I'm trying to make this sound as though I don't know anything about this, but we've worked very closely over the last year or so to look at this. So we've created a public dialogue process where we went out and actually spoke to members of the public to ask them kind of what their views are around a lot of these issues around whole genome sequencing and its use in newborn screening. And at the time you were on secondment to the UK National Screening Committee. Why was it, do you think, that the UK NSC was wanting to be involved in the public dialogue?
Well, I think, interestingly, both Genomics England and the Screening Committee think it was their idea, but I think it just came together perfectly well timed. From the Screening Committee's point of view, I mean, they've long recognised that genomics is likely to become a bigger feature of screening in future, and they also recognised that early engagement would be important here. So that was their real motivation. But the dialogue is going to feed into their work, probably in a sort of closer time period than to Genomics England's, in use sort of maybe longer term work programme. It's informing decisions and considerations that they're having right now on particular screening programmes. But they're also, I think, keen to view this not as a one-off. The dialogue doesn't provide all the answers, we're done now with that. I think any kind of ethics and engagement reflection should be seen as a reflective, ongoing process.
Yeah, absolutely. And I think we're going to return to some kind of the ongoing engagement issues that in a bit later. So on the subject of dialogue and the public dialogue, let me turn now to Rebecca Middleton. I think we at Genomics England occasionally forget that Rebecca has a whole other life and job away from Genomics England. Rebecca runs a highly successful communications consultancy in the Midlands, but to us, as well as for this, Rebecca and her family are participants in the 100,000 Genomes project, and Rebecca is the Vice Chair of the Genomics England participant panel. Rebecca was also part of an oversight group that was set up to shape and inform this public dialogue project, and gave us some insights into the public perspectives on the implications for the NHS and society of using whole genome sequencing. Let me start with a question for people who might not be familiar. What is the participant panel, and how does it work, and what's your role?
So we sit very much at the heart of Genomics England. The panel was formed in 2016, and I'm proud to be a founding member. We're there to ensure that the patient voice is represented at every single level of Genomics England and is heard when key decisions are being made, especially those decisions that concern our data, how it's stored and who accesses it, and to make sure that it is indeed safe. On the panel, we are all 100,000 genome participants, or our family are. So we all have our samples in the National Genomic Library, and we're all invested in the success of Genomics England and all of its projects. And we're a diverse lot. We come from every corner of the UK. We all have very different experiences as rare disease or cancer patients, and different experiences in life, which we all bring to the table, which ensures that we really do keep Genomics England account every day.
Absolutely. And I remember the phone call when I asked if you'd be willing to sit on the public dialogue oversight group. So we had a group of 20 to 25 people that provided input and, helped look at the materials and help us design the process of asking the public about their views and their aspirations and concerns about whole genome sequencing in newborn screening. Why were you interested in the topic? What made you say yes when I spoke to you?
I suppose I do have a background in communication, but I am a patient, and I have been through various kind of NHS pathways as well. So know what it feels like to kind of be on the receiving end, and know how important it is to listen. And Genomics England really are a good example of how listening to patients and participants has changed the design of their service and made a real positive impact. So I wanted to kind of see that expanded and see that grow, because there really is power in listening to the patient and listening to the participant and ensuring that there is positive kind of change and impact from that.
Yeah, thank you. And so, a public dialogue process where you're going out to people, to members of the public, recruiting them to kind of join workshops to kind of discuss topics like this. There's obviously kind of a little bit of a difference between a member of the public who perhaps has not been affected or not needed to know about what genomics is all about and things like that. What was your role on the kind of oversight group in terms of what you did for the dialogue project and how you fed into it?
So on the oversight group, we were all there to ensure that we would guide and challenge the process to ensure that it was representative as possible, ensure that we had a good open dialogue. For me personally, as a rare disease patient, I wanted to ensure that the patient's views were represented in that dialogue. So let's take the case study from the slide pack and make it real. So we invited rare disease patients in the virtual room to share their experiences and share their thoughts and how they have been through a diagnostic odyssey, or they have been through kind of various NHS care pathways, what that felt like, and what they have learned from that. And the participants, the dialogue participants, were able to ask some challenging questions and help unpack and tackle some of those ethical questions as well. And the feedback that we also had from the dialogue was that really added to the richness of the dialogue, and that they really got to understand those topics and those issues. So it was really great to see.
And in terms of the kind of feedback, the dialogue report is available on the Genomics England website for anyone who's interested in finding out more about it. What for you were kind of the standout points that the participants in the dialogue, 130 of them, kind of came back to us in terms of what their kind of messages were around the use of whole genome sequencing in newborn screening?
I think it was really positive that they were positive, that they saw the potential, and that they were optimistic about let's go forward and explore what this actually means, and that was fantastic. What we, as a panel, what we're also really excited about is that they absolutely recognise that we need to take our time to do this right. Not only going forward for a screening programme, but also now we're talking about the pilot programme, we're talking about the vision for the pilot programme. And they understood how important that was, to ensure that we get things right from the get-go, to ensure that we look at what resources are available, to ensure that we look at the training available. And they understood that the patient journey, if you like, from end to end should be thought through and considered. They also picked out trust, something that Catherine mentioned that is so critical, that we need to build that trust. And to build that trust, you need to let patients and participants in. And again, let them in from the get-go, which is fantastic, which is why we are here today talking about the pilot, and ensure that their views are represented again at every point of that journey. Because by getting them involved in the design of the programme, we are ensuring that we have transparency, that we're breaking down those borders, and we're exploring what's going right, what's going wrong as well, and having that honest debate. And if we can get all of that right, and if we can ensure access as well, ensure that every part of society has access to whole genome sequencing, and that experience is a good one, then they are positive. So yeah, as a panel, we were kind of delighted to hear that they'd picked out all these topics and issues that were very close to our heart too.
Absolutely. And I mean, going back to this issue of kind of motivation or positivity around this, I think, one of the, in making comparisons, say, with the 100,000 Genomes project of which you're a participant, and this potential scheme where we are asking families whose babies are perhaps otherwise healthy to have their DNA sequence in order to potentially find something wrong with them. Those potential ways into wanting to be involved in a project like this perhaps do vary between, healthy, for want of a better word, and patients like the participants in the 100,000 Genomes project that have a kind of a reason, a condition, an illness within the family to take part. Is there a big difference between, you think, the motivations of participants and the general public? Does that?
Absolutely. We as participants joined the project because we either have or a suspected rare disease, or there was a cancer, and we wanted to kind of explore the genomics of that. The dialogue looked mainly at the public who had a wider experience of the NHS and perhaps didn't have that experience of living with a long-term condition. However, I think if you look at both kind of sets of groups, kind of participants and also the public, we all identified these universal truths or universal principles, really. And that's where we kind of share that common ground and alignment that, no matter what experience you have, we all, as patients and participants and public, want to be involved in the process. And they called for co-production. And again, it's great that here we are at the Vision launch. And that's exactly what we are doing as part of the pilot. We are co-producing this, and we are ensuring that we are listening, actively listening to patients and getting it right. So yes, there are, as you say, very different routes into kind of genomic testing, but we all want a good experience. We all want to ensure that everybody has access to this, and we all want to ensure that this is a successful program that delivers results for newborn babies and research going forward.
Thanks very much, Rebecca. If there's no other comments from there, we'll move on to Alice now. So for the past few months, Alice has led the team at Genomics England who are exploring the potential of the newborn sequencing initiative and who have been setting up programs of engagement and dialogue with key stakeholders from across the health and science community. Alice, how has the kind of the things that we've just been talking about now, the dialogue, all of the other initiatives, how have they kind of helped shape the work that you've done so far in developing a vision for the Newborns Initiative?
So I think for me it was a fantastic opportunity because I came into this role, I think it was around May time, just around the launch of the public dialogue, and it was brilliant to come off the back of a piece of work like that and really have that at the heart and the start of this journey. I think what came out strongly to me was quite similar to sort of what Rebecca was saying around that actually we need to take our time on this and think very carefully about how we do it, but we also need to make sure we're listening to all the different communities involved in this and engaging with them in the right way. And I think really, for every aspect of a programme, as you start to think about what a programme could look like in this space, you need to be thinking about it in terms of the different frames of both the scientific aspects, the clinical aspects, but also the ethical aspects, and also what the experiences are of the families and the sort of people around that will be going through the journey in this space. And so really to sort of draw on those kind of areas, we've built a team really within Genomics England where we try to bring in that expertise within our team, so that's kind of very central to how we're approaching this. But also one of the things we felt really important to start was to have a really strong steering group supporting this. And I know we've got Sarah Jane who will talk a little bit more about this later, but I'll put our hands up. It is a very large steering group, but one of the reasons for that is because there are so many different communities involved in this. So actually, we felt it was really important to have those voices heard and actually have that representation. And that steering group really will be supporting our team over the coming months and weeks to really start thinking about the shape of what the programme could look like and make sure we're asking the right questions. I think the other thing for us that felt like it was very important was to really, we've had the really strong signals from the public dialogue to start thinking about kind of their kind of excitement around this and where the potential is and their concerns, but actually to also really talk to all those different other communities. So we set out on doing a series of what we called expert stakeholder interviews, where we tried to pick people from the different groups that be involved across the pathway. So different healthcare professionals, people from rare disease charities, people with ethics backgrounds, really to kind of get their views and thoughts on actually both what the potential of what we could do in this space are, but also really what the kind of concerns and challenges are, and really start to think about some of the really big questions we need to be thinking about and asking. And I think, it's very much the start of the journey. These are only early insights, but it's given us a really good start to start really starting to think about the shape and feel of what a kind of pilot could look like in this space, and really thinking about kind of the vision of what we want to try and achieve over the coming months and years.
Thanks very much, Alex. So we've heard some of the kind of background to this initiative, and as I say, the team led by Alice has been kind of trying to flesh out some of that kind of fact-finding that we've been doing and the kind of engagement and dialogue that's happened. So we're kind of now in a position that we're able to kind of set out a kind of initial vision for how we want to take forward this work. Can I turn now to you, Rich, to kind of give us an overview of that vision that we've been developing?
Of course. Thank you, Simon. And really, I think the point to start on, which I think we've heard particularly from Rebecca, is about, we're very much in a conversation here and at the beginning of a process. And we're very lucky to have had the chance to spend a good amount of time already listening in dialogue, the formal public dialogue that we launched this summer, and increasingly now engaging not just with the public, but increasingly, as Alice has said, with experts across the different areas and a very broad range of areas. And I think we're also lucky to have that time. Neena said earlier, the UK is in an unusual position here. I think part of that is that we've got the buy-in to take our time. And I think one of the very clear messages that we've had from the public dialogue, but throughout, is this is enormously exciting. It's important work, but do this right. Take your time. Don't rush it. And I think that's a really important message, and it runs through what we're doing. We're, just trying to advance my slides here. I may ask for the team to help. We've drawn out a representation of the process we'll go through. I don't think I'll call it a timeline even, because what's important is doing this in the right order and with the right steps. We're right at the beginning, and what we've been doing, and we'll hear more from Sarah Jane about the NHS steering group that has helped us, together with the public dialogue, develop a shared vision with the NHS on what the future might hold, what a potential research pilot could look like. But it's very much at the beginning. This is continually listening and developing and iterating that vision. We hope to publish that vision in the next few days so that people will be able to see that, be able to respond to it. And we've got various aspects of formal dialogue with people, but we really want to hear people's views broadly across the piece. So we're there at the beginning of this process. It's about not just dialogue, but also throughout the process, what's very clear, as Catherine said, we heard from the Task and Finish group that was set up in response to the Chief Medical Officer's request. This is about developing evidence, not making assumptions that you might be quite confident of if you have a particular opinion, but actually developing an evidence base that can inform in a stepwise manner, first of all, how you might deliver a research program, but secondly, then that it's a research program to develop evidence that can inform future decisions, whether or not this is something that should be adopted in mainstream care, should be a long-term service. And so it's putting in those steps and those processes and not assuming that you'll pass through. So what are the areas that we're exploring in the vision and we're anticipating exploring in this programme? So I think really there are three broad areas that we're looking at where we can see the potential value for whole genome sequencing sat alongside the conventional heel prick test to allow early diagnosis of treatable disorders, the sorts of conditions that are currently included in the heel prick test, but unfortunately one doesn't have the wherewithal with the technology before whole genome sequencing to detect them. So those sorts of conditions where, if detected early, there is treatment that could have a major impact on outcomes, and the sorts of things that would cause problems early in childhood. So that's the first area, and that requires the generation of evidence in terms of what that, not just what the potential impact is, but we need to know what the real impact would be, not just in terms of benefit to patients, also in terms of the resources required in the health service, the training required for different players in the health service, from midwives through to genetic counsellors and through to treating teams. What information you would absolutely expect if you were one of these parents receiving a result, the clarity of communication, how that would be delivered, so the feasibility as well as just the evidence. So that's sort of area one that we're exploring. The second area we're exploring is the potential, with the consent of families and participants in the programme, to develop, to explore the research benefits. For example, not just taking the benefits that we have today in terms of the knowledge of, for example, a particular condition that one might diagnose with a genome, allowing you to use a treatment we already have evidence for, but actually creating a platform where we can make improvements on the treatments, the diagnoses that we can make, and providing that platform so that we don't just stand still, but we improve with time, not just for the children of tomorrow, but also people who've joined our programs already. And then there's a third area that we will be exploring through this, which is the potential and the value and the ways in which we could use a genome and genomic data as a resource throughout the lifetime. And I think this is a really interesting and powerful concept. It's also one, I think, that we will take our most time to develop our view on how we do this. There are many questions that we'll be uncovering. So I think what we'd anticipate is that we'll be tackling these different areas at different paces through a programme. We'll probably find that concept of the genome as a resource to be revisited is the one that we take slowest. And a lot of that is engaging in dialogue with people. As Catherine said, these aren't new questions. They're not things that people haven't thought of before. But that doesn't mean we know exactly what the right answers are either. And I think we have to be honest about that. But there is, immediately one can see the potential value of a baby, perhaps who's born, is well when they're first born. They don't have any of the maybe few hundred conditions that we know you can respond to, you can treat initially. But 6-9 months down the line, they get unwell, maybe they end up in intensive care. Well, if their genome's there and available for analysis, then looking there for answers that they need to guide their care becomes something that I think we'll be relatively comfortable with. But there are many other questions that we'd want to explore. I think just to emphasise again on the sort of the feedback and those treatable conditions, as Simon, you said at the beginning, this is talking about this in a postnatal context after babies are born. We're not talking about antenatal care or prenatal care. We've already touched on, others have already, about some of the challenges. There are many, many questions here, and that is why we need to take our time as we go through. And today is too short to list out all of the areas we've already been talking about as an NHS steering group, but also more broadly. But just to sort of give a flavour and to touch on some of them, I think is useful. For example, we might say, well, we'll look at conditions initially that are like those that are returned on the current heel prick. We need to work through in real detail what like those conditions means in the context of whole genome sequencing. What are the thresholds for feeding those findings back to families? What do families expect? And so forth. So developing and evolving that approach is really important. I think one of the key things we've been talking about today, and we've been talking to people on the steering group and elsewhere a lot about, is capacity in the NHS. The NHS right now is stretched. The NHS is always stretched, and we need to be aware of that and ensure that part of what we learn through a pilot is how we work within the NHS, and what we need to do to expand capacity where we need to, and to make it part of sort of routine care, so it doesn't create additional work where we can avoid that. And also what resources we need, not just for healthcare professionals, but for families as they go through this process at the beginning and throughout. And I guess it's worth also just being clear on what sort of program we're talking about here. As I say, this is, our view is still forming. We're in really active discussion, and there are lots of views on this. I think our experience in this country through the 100,000 Genomes project and through the establishment of the NHS Genomic Medicine Service has given us a really good idea of the sorts of approach we could take. And our current view is that this would be a research program. As we've said, this is a research question at the moment. We don't have answers. This is research. So it would be performed under a research ethics framework. Families would go through a formal consent process, so they would choose to join it under that, through that process. But it needs to be embedded in the NHS for us to, first of all, learn what we need to learn, but also so that we begin to build some of the know-how and the future infrastructure. If the evidence tells us that this is something that should continue, it will allow us to embed that infrastructure. It's very much like the approach that was taken in the 100,000 Genomes project. So you both learn from the NHS experience, but you also, through the process, help the system to learn and adapt as well. Yeah. And I guess just a couple of things to sort of highlight on perhaps what this programme is and isn't, and what we do and don't expect to do. We don't know yet how big a research programme would need to be to answer all of these questions, but we know it may need to be up to 200,000 babies or families who join the programme to give us the sort of weight of evidence. That's something that we'll learn as we go through the process, how many families we need to be confident of the findings. And it's very much about basing that in terms of the evidence that would be needed by the NHS, by the screening committee, by others to make the right decisions on the basis of the evidence. And I think just a couple of points to emphasise, as well as the point about this being a postnatal programme. We're not anticipating feeding back findings that aren't relevant in early childhood. Certainly not findings that would be relevant in later life, for example. We often get asked whether we'd be feeding back things that might help understand whether people might be at risk of Alzheimer's, etc. Certainly not. And I think the key thing here, and it sort of goes back to the discussions we've been having earlier, this is about both being transparent as a programme and transparent with every individual involved. So this is a dialogue in terms of how we're developing a future programme, but also with all of the individuals involved and the families doing this with their information, with their buy-in, with their consent, and with their guidance. So hopefully that has given you the shape of where we are in terms of our emerging vision of where we are with the newborns programme. We're at an early stage, and this is like one event to start to share the news of where we are. But the important thing is that it will continue to be a dialogue broadly.
Smashing. Thank you very much, Rich. And I think in particular that kind of question about what this is, we've been using the word project, we've been using the word initiative, we've been using the, various different ways of describing this. It's a research project, but it's not just a research project. There are elements of kind of clinical development, but it's not just about that. And there are certainly elements potentially of NHS transformation, but it's not just that as well, a kind of hybrid of all three.
Absolutely.
Excellent. Good. Which kind of brings me on to the kind of the final, last but by no means least of our speakers. Thank you for bearing with us over in our Birmingham studio, Sarah Jane. Sarah Jane Marsh is the Chief Executive of Birmingham Women's and Children's Hospital NHS Foundation Trust. I don't know how she fits all of that on her business card. But she's also the chair of the NHS's Maternity and Young People's Transformation Programme. And she has very, very kindly agreed on behalf of Genomics England and NHS England to chair the steering group that Alice mentioned first in the project. I've been to one of your steering group meetings, Sarah Jane, and I've been bowled over already by the kind of energy and enthusiasm you bring to all of this, and trying to kind of herd all of these cats, for want of a better phrase, into kind of, you know, a way forward for the Genomics England programme. You haven't got a background in genomics. What was it that interested you in wanting to take part in this? How did we manage to twist your arm?
Thanks, Simon, and thank you. I've really enjoyed the session so far, and I've been learning along the way again. So brilliant contributions from everybody. I'm really passionate about the role that science can play in the future of healthcare. I think sometimes it can feel a little bit over there to people working in frontline services, but actually I think science could answer some of the challenges that we've got. We've already seen, as other speakers have mentioned, the impact that personalised medicine can have. So for me, you know, organisations like the one in which I work need to really grasp this and see it as, you know, something that we need to be very, very much involved with going forwards. It's really important for everybody right across the NHS to understand this and think through the practical implications. And, you know, I really want to bring that as well. There's no point having the best strategy in the world if you can't lift it off the paper and put it into operational reality. And then if I'm honest, Simon, I think one of the other things was the people. I always, when anybody ever asks me to do anything, the answer really relates to the people that you meet and the sort of energy, enthusiasm that they bring. And whilst this is obviously a massively complex challenge on all fronts, when I met the people involved in it, I just thought, actually, you know, we've got shared values, we've got shared ways of working, we're going to listen to everybody along the way, you know, patients, families, citizens, clinicians, managers, whoever they might be, and yeah, that was what made me think, right, this could work. And then of course the lovely Sue Hill, who I worked with last year at NHS Test and Trace, wouldn't have let me say no, even if that had have been the answer anyway. So she did the final arm twist at the end. But no, I'm delighted to be involved, and yeah, just like everybody else, just hugely passionate about what we can achieve.
Thanks, Sarah. And yeah, I know what you mean about Professor Hill. It's very hard to say no to, isn't it? So what's the role of the steering group then? What do you provide to this programme?
I think there's a few things. I think the first is some structure around the conversations that we need to have. Others have alluded to the complexity here, but in some ways we need to try to remove some of that complexity and put some structure and some small decisions that we can keep making to move forward. So as Rich said, we don't know the answers to all the questions, but we have managed to already redefine what some of those questions might be and narrow the scope of them, so that we're able to hold some structure and process around that. There are clearly huge ethical debates here, but there are major practical ones as well. And I think the steering group has got a range of people on it who are able to bring those different perspectives. So we've got people who absolutely understand the science, and people who in the first meeting said, I don't really know what's going on here, but I know I'll have to live with, whatever the consequences are. So we had to go off and have a teaching session with Rich, so we could actually learn what this was all about. And I think that's really a very strong thing to have. We don't want this to hit operational reality, a few weeks before we actually want to do it. So we've got that whole spectrum of people involved. I think I also see myself, and I know there's many other mechanisms in there as well, but just safeguarding the role of the patient and the citizen and the professional groups as well, and just making sure that there's a final check, really, that everybody has had an opportunity to have their say and be heard. That doesn't mean that we can always do everything that everybody says. The journey on the vision document has been interesting because there are some people who've got quite different views. I think that's very healthy. I see my job as, making sure all those views are heard and we come up with a fair way forward that people are comfortable with, and feel able to support and put their name to.
Smashing. And both from your experience in your own hospital and also through the transformation programs that you chair, what do you see as being the kind of main potential benefits to maternity services from doing something like this?
Yeah, so in my time, certainly in the Children's Hospital, we've got a major rare diseases centre in Birmingham. And I've met with many families who for years and years have been trying to get answers to questions about their child and family health. This obviously has a big impact on outcomes, but it also has a big impact on childhood. Children cannot be children because they're constantly attending appointments here, there and everywhere because we can't get a diagnosis for the condition, we can't get answers. And often by the time that children arrive in a place that might be able to help them, it can be too late, we can be far too far down the journey. So for me, one of the biggest potential impacts would be on the experience of children and families themselves. I absolutely believe in, that we need to put children at the heart of healthcare. It's a speech I often make, but, children aren't a specialty. They're a population group that we have to look after well if we believe in the future prosperity of this country. They're our opportunity to break cycles of ill health and deprivation and inequality. So I think the potential to impact on children and young people at the earliest stage that we possibly can and make a difference, to me, is the real driving force. I think there are going to be impacts in maternity services. I think we learnt in the 100,000 genome that whilst we could get, great outcomes from what we were doing, the sun's just come out to tell me that that the children are shining and supportive. Whilst there is, it's a great thing to do, there are practical implications as well. Maternity services are under a lot of pressure. Those that work in, more generally in maternity will know about some of the safety concerns, and Donna Ockerton's reviewing into Shrewsbury and Telford and so forth. It's really important, again, that we understand how we're implementing this in a broader NHS context. So I think the benefits are, worth it. We need to work through all of that as part of the steering group, but we do need to make sure that we understand the way that work will change and the additional pressures that it might put some of our services under. Certainly in the short term, where we're running dual systems potentially, hopefully over time, it might make processes and systems a lot clearer. And actually, it could make for a more efficient and effective maternity and childhood journey, which would obviously be our hope.
And Sarah, as your kind of NHS colleagues kind of hear about the fact that you're involved in this group and are perhaps wanting to ask questions about kind of the programme and how it might work, is the feeling one of nervousness, excitement? How are people kind of reacting to the setting up of the programme and the vision?
I think that people can see the challenges, particularly some of the ethical challenges and the complexity of the implementation. But I think that many of us who lead in health services can sometimes feel very sort of under pressure with the day-to-day operational realities in the NHS. We're under huge pressure at the moment, serving our populations, urgent and emergency care, elective backlog, which is really important and so forth. I think having these projects that give us hope that there may be a different way of doing things, that science will be able to unlock answers to really important questions, and that we'll learn things that we don't even intend to learn when we set out, which I'm sure will happen, as it did with the 100,000 genomes. It was about rare disease, but we started to learn things about common disease along the way. I think they're the sorts of things that get people excited. So a few people have said to me, "How did you get that gig?" But in general, it's real enthusiasm and people really wanting to get involved. And I think that's another important role for the steering group, is to make sure that it's just not a few people over there doing this work, that we are having those conversations and we're talking about this in the mainstream of NHS conversation. And I'll certainly be out and about on the sort of NHS conference circuit, really just trying to talk about this project as a really important thing for the NHS as a whole going forwards.
Thank you very much, Sarah. That's really inspiring. Thank you. Lots of questions, so many questions. I'm going to use my chair's privilege to kind of ask a couple of questions that I know that when we go out and we do some engagement that lots of people talk about. I think the first one, going back to those kind of the main aims around the programme, the first one about kind of looking for specific conditions, specific genes, specific variants to kind of make diagnoses from children area. A lot of questions around kind of, how will you decide, what conditions that you're able to look for, that I think people have done work on looking at, maybe up to 600 different conditions that you may look for. Some people say, well, it might be a lot more, it might be a lot less. How is the decision going to be made around kind of what's on that list of things to do, Rich?
So I think that's, as with everything in this program, that's something that we will want to share our thinking on. We're developing a view. In fact, we've set up a little group from the NHS steering group to begin to think how we might shape this. Again, back to the theme of we're not starting from nowhere here. These are things that people have thought about long and hard. For example, the National Screening Committee has obviously thought for a long time, and many people internationally, about some of the considerations here. But there are obviously also aspects that are unique to using whole genome and other sort of particular aspects of what we're exploring here. So there will be, what we're looking to do is to develop a structure, as Sarah Jane says, to our thinking, and we can agree on some core principles. There is, of course, a lot of devil in the detail, and one of the things that we absolutely commit to is that we will, to every condition, every gene, every patient pathway, we need to give a fine-tooth comb level of detail about thinking about every step in that process. At the same time, and that's all the way from, do you include a condition, or what do you need to do before you're ready to start saying you'll feed this information back to families, because you can't start before you're absolutely sure you're ready. But at the same level, a lot of the questions, it's about simplifying them, if you like, as Sarah Jane says, thinking what the core of the question is, not sort of hiding ourselves in scientific detail, actually saying what are the really important things that participants and experts would expect. For example, when should these findings be relevant to families? Who should we be thinking about the benefits accruing to? We're talking about the baby's genome guiding their own care, and also what level of confidence do people expect before we start returning anything to them? Those sorts of big questions, which then you can help inform the really detailed view, condition by condition, gene by gene, family by family.
Great, thank you very much. Another question, which, because I know that there are a lot of people from industry hopefully tuning in today. Alice, the kind of second aim, which is about this, I think Rich called it a kind of platform for innovation. How will we work with industry? How will Genomics England work with industry in terms of kind of, what it is that they have access to, how they will be able to kind of create that kind of acceleration in new treatments and drugs that might have a benefit?
Yeah, so I think, one of the things about that second aim is there's a huge amount of potential in that. What we really want to do is help drive research into new diagnostics and treatments. However, I think we're all aware, and it's come up in the conversations today, that there are, public concerns around that use of data, who accesses it and how they access it. And I think what we have is a really strong foundation at Genomics England that we can build on in terms of our experience of actually ensuring that we put the right levels of controls and governance around how people access that data. But we also need to really understand what that looks like in this setting, because there are some differences in terms of the data we might be collecting and the potential of what we might do with that. I think, again, one of the things we've felt was really important is to have that kind of transparency and openness around that discussion. And so one of the first things we've done is set up a discussion which is actually happening this week with people from public dialogue backgrounds. Rebecca's joining us as well with her perspective as a participant, and some members from industry. So we can start that conversation about thinking around how do we look at what the potential of using this data could be, but also what are the considerations around how do we ensure that we both retain that public trust and confidence in what we're doing, but also thinking about the types of things we might think about in terms of that governance and control. So really it's kind of the start of the conversation, like many of the things like we've said today of where we're at. We're starting a conversation. We don't have all the answers yet, but I think in this space we have some of the benefits of building on the foundations of some experiences we have as an organisation, which we can take forward as part of that conversation.
Yeah. And Rebecca, not to put you on the spot at all, but what is the solution? There is this, as Alice says, a kind of awareness amongst the public about access to their data, particularly by commercial companies. But on the other hand, we know, through talking to the participant panel, that actually, if you have a rare condition, then that's exactly what you want. You want, people to be looking for solutions, cures, whatever that might be. How do you kind of find that middle road that keeps everyone?
I think the two key words are transparency and benefit. So, in terms of working with industry, people automatically get scared and worried, what are you going to do with my data? But by kind of being transparent, by ensuring that, patients and participants are in the room when there's discussions are happening, that is a good way of kind of breaking down those barriers and ensuring that transparency. And when we've done public dialogue before, people do understand that you need kind of commercial partners to look at your data to find results which are not only going to help you but families and other generations, and they're supportive of that. So explain the benefit of that and explain the benefit for all as well. So I think it's about having an eye-to-eye level conversation with the public and not being scared, kind of throwing open the lab door and letting people in and letting them see what you do and see how you use our data. It really shouldn't be magic, because at the end of the day, that data is our data. It belongs to people. It will eventually belong to babies who will grow up to be adults. So, let people in and be transparent about that process.
And Neena, your experience with the work that you do in the neonatal sphere, you talk about the fact that actually families are very willing to share their data for research. What's the kind of secret to doing that, if it is a secret?
Well, no, I would echo absolutely what Rebecca's just said. It's about being transparent and open and clear about how the data will be used, what it's being used for, who makes those decisions and how those decisions are made. But it's also, so it's about trust in that process. It's also about benefit. Now, benefits can be individual benefits, or they could be broader societal benefits. And of course, one of the dialogues that is ongoing, whether it's whole genome sequencing and the benefits that arise from that, whether it's medicines development, whether it's vaccines development, it's also about how will the benefits that a pharmaceutical company, say, or a commercial company, what is the balance of benefit to them, to their bottom line and their shareholders, versus the benefits to public and society? And I think that, I know, because this is what families say to us, they want to be reassured that the benefits are equitable, that it isn't a polarized set of benefits, so that, yes, a company needs to sustain itself to do the development work, the research and development that it wants to do, but also the public needs to be reassured that those benefits are translating back to societal benefit. And we've seen some of these discussions played out during COVID, of course, with vaccine equity and inequity. So part of the dialogue will be ensuring that the benefits are equally realised for wide societal benefit.
Mm-hmm. Thank you very much, Neena. A question from the chat. This is from Sarah Hunt, and it's a question around how the programme will work with the UK National Screening Committee. And I think maybe, Catherine, to you first to kind of talk about. So the Screening Committee have a set of principles about which kind of things, screening programs should be available on the NHS, and then maybe tell us about kind of how a relationship might work with the Screening Committee going forward. So these principles that the Screening Committee have perhaps might be different from the principles around gene selection for the program and things like that. How do we navigate that kind of differences, and how does that work?
I think actually the principles are broadly aligned. Actually, it's just there's room for interpretation between them. So, broadly, it's about having, serious conditions. There has to be something you can do about it. Has to be a fair use of public money. There's certain principles. I think, there's broad agreement. And actually, when we did the public dialogue, sort of unprompted, really, they all came out with very similar similar ideas and were sort of signed up to that and keen for that to continue to be the criteria going forward. I think what's going to be really important with this research programme is the evidence that's going to come out of it. That's often the barrier to getting a screening programme into the NHS, because they have, rightly, I think, a very high bar. They need to be sure that this benefit-harm balancing act is going to work, come out the right way. The benefit is going to outweigh the harm. They need to be very sure about that, and to be sure about that, you need evidence. You need to know what happens to families, what happens to children who get this diagnosis. Is it better for them to find out early about something than just finding out when the condition, comes to bear? Yeah, exactly. Why not wait? If it's something that tends to happen at 6 months or a year or 2 years, what is the benefit of knowing at birth? So that's going to be really important and really interesting, actually, to see what comes out of this research programme.
And it seems to be that a lot of the discussions and perhaps a bit of the heat is around the definition of actionability. So actionability in terms of what we can do about it, perhaps means different things to different people. Perhaps.
It does, although I should say the screening committee already does have a very broad view of that. It's not that they're just, it has to be, a medicine or some kind of therapy. Some of the screening programmes already in the NHS, are more about, diet or sort of lower level, cheaper kind of interventions. So they're definitely very open to that, but it's about just showing that this kind of early diagnosis is better than waiting for a little bit longer.
Yeah, thank you, Catherine. And Alice, in terms of going forward, how will Genomics England be working with the screening committee?
So I think it was important for us to have a representation on the steering group from the screening committee for that reason. So Anne Mackey from the UK National Screening Committee sits on the steering group. But also I think, as Catherine said, a lot of it is about when we go into this programme, we need to think very carefully about both the evidence we need to gather, but the evaluation also that sits around perhaps some of the big aspects. So there's evidence around actually, how many of these conditions you can find and how you treat them, but also actually evaluating some of the outcomes and thinking perhaps longer term also some of the data we might need to collect. And I think that very much having that input and that dialogue with them, so we really shape that design the right way to give them the information they need to then inform those decisions down the line as to actually what a potential clinical service could look like and how that fits in.
Great. We have a limited amount of time left, and I'm going to try and plough through as many of these questions as possible. This one might be for you, Sarah Jane. Outside of the consent issues, this is from Megan. Outside of the consent issues, one of my concerns is the additional resource we are going to need. More staff in the genomics workforce, more counsellors, more nurses and midwives trained in this area, more money for the genomic laboratories to actually be able to stand up this service. This could mean a massive increase in samples without the technology and IT systems to support this, and we have to provide for patients with clinical need. How will this programme manage what is achievable? Now, this is the almost the age-old thing about NHS resource and NHS change and steering the turning the supertanker and things like that. What's the magic solution, Sarah Jane, to how we do this?
Does Megan work for Birmingham Women's and Children?
Yes,
that's my first response, because I think what Megan said is what staff up and people working in the NHS up and down the country will be thinking. I think that's one of the really important things that we need to lead through the steering group, is that starting off small and learning as we go about what resources do actually need to be in place to make this work. The more efficient and effective that we can make it, the better. But we will need to invest in the services if we, and we need to make the case for that. And I think that's part of the work of the group. Now, I think some of the excitement that we've got so far comes from the fact that we would be potentially changing pathways of care. So, not all of it is going to be additionality in the end, but clearly there is going to be a period of time where we've got double running and, and so forth. So part of my role and part of the role of many of the people embedded in the NHS on the steering group will be to be honest about what those resources are, because if we're going to make the impact, we know they need to be in place. And I think that's, it was probably quite a brave decision to ask someone like me to do that, knowing that I would keep repeating this, and you've got to give us the tools to be successful if we're going to do this well. So Megan, I will have your question and challenge on my mind, I think, in every meeting, every step of the way. To me, it's the crucial question.
Megan, we'll get your question framed and put above the in the boardroom. Okay. There is another question that I'm kind of looking at Catherine here, but it's about ethics. But obviously, you know, just because you've got ethics in your title doesn't mean you don't hold the card on this. What would the ethical impact be of finding an illness that would affect someone as an adult and not pass that on to the family, as it would not affect the newborn in their early years? Is it ethical to not provide that information as and when it is tested for? Could it be too late to find out as an adult and then act upon that information? Are we then restricting the choices they have for treatment? How do we deal with that? That was from Katie. Thank you, Katie.
That's a really good question, and I think brings in an important aspect that we've not really talked about today, actually, which is when you find out genetic information about a child, you also find out about their family. So yes, there's the question that was asked about whether, you know, that would have an impact on that child, but what about their family? If it's an inherited condition, it's possible that other adults in their family have that condition. What do you do? And there have been, you know, some discussions that I've been involved in at the screening committee of thinking about the established approach is you think about the individual as the beneficiary of screening, you know, whatever stage in life that is. So at this point we're talking about the baby, the child. Do we need to start thinking about the family as the beneficiary of screening? And I think that's quite a new question and quite a difficult question. So I haven't got any answers, I'm afraid, but just a really important question to flag.
Yeah. Rich, you're frantically signalling.
I think one other important way to sort of think about what the process will be is that the reality of what looking at genome data is, and therefore what, in inverted commas, answers one gets from it. So the genome is 3 billion letters, bases of DNA long. And the reality, just as when we do a newborn heel prick, a complex test is done and very specific analysis is pinpointed on the particular conditions we look for. The reality of a genome is give me a printout of my genome and I don't discover my future. I actually need to do a very specific analysis to ask some questions. And so rather than suddenly everyone knowing what one can interpret from the genome, actually we have the power to decide what questions we're asking at what stage. And so almost we have potential to do some things that might be relevant later in life, but we also have the power to decide together what people want to do and what people want to ask of their genome, if you like. So it's less, sometimes we feel like we're the victims of too much information. Actually, the reality is we're empowered to choose what we want to find out.
Yeah, well, on that note, I'm afraid that we've run out of time. Thank you so much. It's a fascinating discussion, and I feel really privileged to be kind of working in this area. There is a webpage that we've just published on our website, which has got further information about the programme. As Rich said earlier, we're hoping to publish a vision document that we'd like people to have a read of and send us their comments on. There will be lots of opportunities over the next 18 months or so before we even begin a pilot to contribute, to come to events like this one, to feed in your views. And as I say, the engagement programme that we're standing up is an opportunity for us to do that listening and to do that talking. So it only remains for me to thank Rich and Alice from Genomics England. To a certain extent, they get paid to be here, that's all right. These other people have all given their time for free, and we're very, very grateful for it. To Sarah Jane Marsh over in Birmingham, thank you, Sarah Jane. To Rebecca, to Catherine, and to Neena, to Professor Modi, thank you all very much.